which I will be presenting instead of Dr. Avramovic, who had to leave early. So this is an everyday case. It's nothing special. We all know what the guidelines say as far as bifurcation lesions are concerned, but we ended up doing things here a bit differently, so there will be a lot of room for discussion. This is a 75-year-old man who presented to our emergency department in Isola with a non-ST elevation myocardial infarction. His EKG was unremarkable, while point-of-care ultrasound showed wall motion abnormalities in the LAD territory. We performed coronary angiography. So there was an intermediate lesion in the RCA, which I will not show. Just hope this will work. Sorry. Okay. Maybe I have to sign in. Just give me a moment. This is a bit, maybe I can open it directly from my drive. It's going to be a bit easier. Again, I apologize. Okay, so now it's working. So it's basically Medina 111 LAD diagonal lesion, which we consider the culprit for the patient's symptom and presentation. So I can put it on a loop here so you can see it a bit better. And so we went to work. We kind of decided that there was a high likelihood of the side branch of this important side branch occluding, so we wanted to treat it. And we decided to treat it with a DCB. We decided on treating the side branch first, and then to go with provisional stenting of the main vessel, the LAD. We ballooned the diagonal without touching the main vessel, and we did a DCB inflation in the diagonal. So the first result was okay. There was minimal recoil in the diagonal, so we were optimistic that we could continue with our chosen strategy. We prepared the LAD lesion. This is a semi-compliant balloon, which expanded well. There was minimal wire bias at the bifurcation. So we decided to stent it with a 3.5 by 38 millimeter Onyx stent. We did the proximal optimization. And the first result looked okay. The diagonal was open. The stent was well expanded. Well, here in the aerial view, it looked severely pinched. We consider this to be also recoil after DCB, and there seemed to be some dissection. So at this point, the patient was stable. He was symptom-free. His EKG had no ischemic changes, and the flow in the diagonal was preserved. However, we did not like how stenotic the diagonal was, and since it was a big branch, we decided to treat it, to stent it. We went with TM protrusion stenting. We put a 2.5 stent in the diagonal and a 3.5 balloon in the LAD. We deployed the stent, we retracted the balloon, and did kissing balloon inflation. And then, which is not shown here, we did another proximal optimization technique. Let's see. And we were satisfied with the result. There was timid free flow in both vessels, both stents were well expanded, and we stopped here. So as I said, we know what the guidelines say. My boss presented them yesterday on how to treat provisional lesions, but we ended up doing things here a bit differently. So my first question here is, does anyone think we could have just left the diagonal alone, untreated? There was severe osteal disease in the diagonal, and it was an important branch, so I still think it should have been treated. But one thing I think we could have done better here is that we could have treated the main vessel first and did the DCB later. Because what we did is we dilated the diagonal, did the DCB, and then went to the LAD, which led to plaque shift and ruined our first DCB result. So my first question here is, let's go a bit back maybe and look at those pictures here. Looking at this picture, did the diagonal need bailout stenting?
The pot is not a pot. As you can see, the proximal part of the, go
Here.
next video. And the follow, and you see the diameter of the proximal segment, the main vessel, has the same diameter as the main distal branch.
Okay, I understand.
So this is not a true pot. So, as you can see, the carena is in the alignment of the proximal segment. This is not sharing the flow. So if you do a true pot, now you can still save the problem. You use a bigger balloon to have a real pot. And after that, if you have been, if you are thinking, much before the problem, you normally have a loop in the wire in the distal vessel, because the loop helps to make the wire exchange. And it's very important to have this loop, just to be a bit longer than the diameter of the distal vessel. So when you have this loop, you pull slowly, directed towards the side branch, you enter the most distal cell. And now you will be able to do something different than tap, which is T. You have tap here because you are not entering the distal cell. So, because the carena was blocking the side branch.
Okay.
So the carena moved to the side branch.
Okay, I understand.
So it's very important to have the two diameters. This is the basic of the bifurcation stenting. The very beginning of the bifurcation stenting. Two diameters.
We did use a 4.0 balloon for the POT, but I do agree that this segment is not as well expanded as it should be. It does look almost the same diameter as the 3.5 stent.
Massive carena shift. You are very close to closure.
What was the diameter of the stent?
3.5.
3.5, and you made a pot with 4.0.
4.0.
Okay. So, first of all, congratulations for braveness to stay there.
Thank you.
It's not easy for fellow to do so. All that Yves said is absolutely right. I personally, there are a lot of things that you can do in this situation like that. First is just to give a nitro weight a little bit and to check a geographic result, and sometimes it improves. The second one, if you don't want to be too aggressive. The second simple thing which you can do is, like in our lab, just to record the intracoronary ECG to check for ischemia. If there is no ischemia, you can leave it alone. The third thing you can do is to do FFR on this side branch and to see if there is a functionally significant stenosis in this way. I can bet that probably that would not be significant. Around 10 years ago, we had a discussion with Bong Fong-ku in Sofia, and about the shape of Carina after Carina shift and relation. That was the discussion in 2016 when I published in Eurointervention the correlation between intercoronary ECG and FFR. And we noticed then that if the ostium is completely straight like a triangle, it is usually significant functionally. If it is like there is some conical shape like in this way, in most of the cases it is functionally non-significant, but we never proved that. That was my personal impression, and he confirms the same after a lot of FFRs after stenting in this situation. We never published that, but this is our shared
Of course,
impression.
it's a question of opinion because the measurement was not done. But I think for the audience, it's very important to see that there is one diagonal. One diagonal. So it means for Bong Fong-ku that one diagonal means a relevant side branch with more than 10% of myocardial ischemia. So if this lesion is significant, this is more than 10% of ischemia. So that's a good idea to do FFR, even why not before the treatment? You just do FFR of the side branch. Cannot be improved by the inflation of by the displacement of the carina. No? So I think this is very important to consider that there is a diagonal. This has to be, but doesn't mean that you have to dilate first. Doesn't mean that you have to begin with the side branch with decay crush with a lot of things like this. Just the provisional. Two diameters. You pull your wire, you enter the distal cell. After that, everything is coming very easily. And in my opinion, if it's well treated at the ostium, the strut you open towards the ostium, open enough the diameter to do a DCB treatment in the side branch. I know that some people are shocked by doing the DCB after stenting the main vessel. But if it's well treated with a fully open ostium of the side branch, then you can do a DCB. Or a second stent if the result is bad.
So we can settle some controversy. If you had done some intravascular imaging, you could have seen what the effect of your pot was and what the diameter of the proximal vessel
I agree.
is, and of the vessel LAD beyond the diagonal. Now, the diagonal ostium is pinched, but don't forget that that's not the only lesion. The lesion extends about 15 millimeters from the ostium, right? Because look at the diameter. So I don't disagree with your plan of stenting it, because as Professor Louvard said, that is a big diagonal and it subtends a lot of myocardium. Your ostium is pinched, but there is disease. I would say about 50% or so, about 15 millimeters in the diagonal. So I know you didn't do IVUS or OCT, but that could have been one step. You could have also seen what the stent strut is doing over the diagonal ostium, because some of that appearance may be because the stent strut is over the ostium.
Okay, here we see that all the experts that promoted keep it simple, safe, and swift are against this strategy, but I personally would perform, if I'm pursuing excellent angiographic result, just kiss and pot, and then to decide if the second stent is needed. The only thing which I will not perform in this case is after TN protrusion to do proximal optimization. In my view, pot after TAP should be obviated. Why? Because you never know where is the tip of your neo-metal carina. Never know. And you can imagine that it is somewhere, everywhere, but you don't know. And the chance to push this carina in any direction and to compromise one of the two branches, you will never see this in angiography. Your angiographic result immediate will be excellent after POT. Always after TAP, POT, you will have excellent angiographic result. The problem, you will recognize the problem several months later.
Yeah, at the end. Yeah, at the end, of course. Of course, just come back to many years in the beginning of the bifurcation club. We had a discussion with Manuel Pan to treat first, to balloon first the side branch, and we were against this with Thierry Lefebvre. We stand the main vessel, we do the pot, and after that we prepare the side branch. We had a randomized trial by Manuel Pan, was in favor of the, he was telling that there is no difference if you predilate or not. And so no difference, I mean, you can use both. But I remember a case I had, that was the beginning of the history. I had a big diagonal like this. I prepared the side branch, I put a crossover stent, and I lost the side branch. I was unable to re-enter the side branch. Here, for example, if you, of course, you exchange the wire to put the second stent.
Yes, of
No?
course,
Yeah,
we
of course.
were wired.
But exchanging the wire, as when you have a dissection like this, can be very difficult. You know, you don't know where you are, and there is no way to know where you are. So I think the rules, you know, they are strict, they are, you know, clear. You have to follow the provisional way. This is provisional, but with a mistake at the beginning.
I'm not very agree because that was strategy of Nordic study. In Nordic they perform exactly what they do. The Nordic one protocol was, yes, I know.
Big one is prehistoric. It was before the bifurcation club. No, something I not told you. Something very important. You see the shame you do in a simulation with the two diameters and the window towards the side branch. You can see it with stent enhancement. You can see it with stent enhancement. You do stent enhancement, you see if you have metal projected in the side branch, which is visible, you have to do a T. You can do a perfect T. I'm against what you say. You can do a perfect T. If you don't have projection of metal, it means that you enter the proximal cell, so now you have to do a tap.
Okay,
T
understand.
and tap are the
Yeah.
same. The T can be perfect if you have projected the distal cell, the distal strut towards the side branch. This is what we try to do with the pullback wiring. Sorry.
Okay. You know, 2 physicians, 5 opinions. That's it. Thank you.
Thank you.
So the next case will be from Dr. Nikolov from North Macedonia.
Thank you, Dr. Velev. Thank you, Dr. Gelev, for inviting Vasilev and Gelev for inviting me, being part of the best Balkan, maybe BBC club. Today I will discuss about the rules are made to be followed, not, as we always say, to be broken. This is a patient, a male, 48 years old, smoker, with 4 years with a diabetic. His father died from myocardial infarction when he was 60. He came to our hospital for regular cardiovascular examinations, where we see normal LV function with some plaques without significant stenosis on the carotid artery, but on the treadmill test, it was severely positive with the pressure dumping on the second level of treadmill test. We did the angio, and there was a LAD stenosis significant in the proximal and distal part, big diagonal with a 95%, 99 with the TIMI2 flow, ramus intermedius circumflex with the distal, mid-distal region with the subocclusion, and RCA with the 100 CTO occlusion. The syntax scoring was telling us that this patient should go for CABG. But the patient, when I explained him on the table that he has to go for a CABG, he strictly said no. So I'm not going to lose time with the guidances. We stop the intervention and take the patient out of the cath lab, discuss with the patient, explain the complexity of the PCA that should be done to him and the longevity of the results. He signed this information consent for complex PCA, and the next day returned back to the cath lab. So we do the transradial approach with the 7 French slender introducer, and you can appreciate the curve that actually in the truncus brachiocephalicus. So this was the...
What is this, the curve? What is the curve?
It's the
It's the Lusoria.
No, it's not.
Oh, you injected to know if it's
Yeah. It was just a huge curve through.
This is the same kind of problem. So if you
Yeah,
push
yeah.
your guiding, it's going to descending aorta. So it's very difficult to manage.
No, it was not illusoria. It was a regular truncus brachiocephalicus, but with a huge curve. Yeah, maybe. We didn't do CT scan of the. We didn't do the CT scan of the patient, but it was truncus, a huge one. So these are the stenosis on the left coronary system on the LAD. You can appreciate the tight stenosis, Medina 111 on LAD and diagonal, pinched ramus intermedius and circumflex in the mid-distal region, subocclusion with a slow flow phenomenon. And LAD, we can say this is a distal LAD or diagonal, maybe we can discuss about that. It's a 95% stenosis. So the decision was, if we go for this kind of complex PCI, especially in a young patient with a diabetes, we should be OCT-guided PCI, because we have OCT, we don't have IVOS in our cath lab. And the idea was strategies to attack the circumflex first. When we finish the circumflex, we go for the LAD system. So you can appreciate the wire. I'm using a PT2 MS wire. It's my favorite wire for this kind of lesion. You can appreciate the curve that before the stenosis there is on the circumflex artery. And we make several pre-dilatation with semi-compliant 2.5 balloon. And this was the OCT run after the pre-dilatation. You can appreciate calcium stenosis in the mid part of the circumflex, and in the distal part you can appreciate the dissection and suboccluded region that is now with a better flow. According to the measurements that were taken by the OCT measurements by Dr. Jovev, he was my associate in the cath lab, we decided to take 3.0 DES for the distal, mid-distal part and 3.5 for the proximal part of the circumflex. And we do the OCT run after the stenting, and you can appreciate in the circumflex well-applied struts, some plaque protrusion here in the mid part of the, and not applied struts on the stent of the mid circumflex. In the distal part, plaque protrusion and not well applied struts of the stent. So the OCT told us that we have to do post-dilatation. So we did several post-dilatation with an NC balloon from the distal to the proximal part of the circumflex, and the result was quite good for angiographically. After it, we attacked the circumflex artery. We put 2 wires. You can appreciate that the diagonal was almost TMIT 0.1 after we put the wire. We made a pre-dilatation with the 2.5 balloon and directly go with the DCB ballooning of the LAD to the diagonal. This was the only DCB balloon that we had at that time in the cath lab. And when we do this, I'm using the same DCB balloon for pre-dilatation of the stenosis of the other plaques of the LAD, and we did the OCT run of from LAD to the diagonal on the left side, and the OCT run of the LAD. You can appreciate that there is a dissection in the LAD on the proximal part and some ostial, but short stenosis of the diagonal, and on the right side you can see the OCT run of the LAD where the dissection in the proximal part, some calcification in the proximate part of the LAD, and dissection in the distal part where we did the post-dilatation. By measurements of the OCT, we decided it was 2.5 for the distal LAD, but we took 275 stent because we were advancing back with 3.5 and from left main to LAD with 4.0 by 26. And of course, to the bifurcation rules, we do pod with the 4.5 balloon in LED prox, rewire, KISS, and repod. And we did the same on the left main to the circumflex. We're using 4.5 for the kissing and 5.0 for a final pod. So this was the run of the OCT from LAD to the diagonal. You can appreciate that there is still dissection in the short dissection in a short segment of the diagonal, but T-3 flow. And this is the run that we did on the LAD. You can appreciate the well-expanded struts. In the distal part, you can appreciate some not well-expanded struts of the LADs here in this region. But it was 2 hours and 10 minutes, I think, in the cath lab, around 600 milliliters of contrast. And we decided to stop the intervention. To finish the intervention, the results was quite good. The patient was stable. And the patient, after several days, went home. 10 days ago, actually, this is 7 months after the intervention, we called the patient for recoro, just to see to see how the situation it was. You can appreciate that diagonal, it's much better flow now, and still the Aramus intermedius is pinched. But the thing that actually took our eyes was the distal LAD stent, where actually there is instant restenosis. According to the OCT that we had 7 months ago, told us that we have to post-dilatate this region, and we didn't. And this is the results after 7 months that we didn't listen our OCT findings. So take-home message, always take syntax scoring when we have multivessel coronary disease, patients, especially with diabetes. We must choose the best pathway for the patient. Is it going to be PCI or a CABG? It should be the best way for the patient. And if the patient doesn't follow our recommendation, refuses our recommendation, if it's stable, you should take out the cath lab, discuss with the patient, sign special information consent for complex PCI, and after it, you call him for a stage procedure, OCT guided, of course. And always listen and follow the OCT findings, because if you don't, then you will go again. This is our old cath lab. This is our new cath lab. We are 5 interventional cardiologists, 1,500 angio per year, around 7 PCIs, from which more than 40% acute coronary syndromes, 80 peripherals, more than 50 CAS. This is our team in STIP, and follow the rules. You will never make a mistake. Thank you.
Did a surgeon talk to the patient?
No, in our hospital, we don't have cardiosurgery. But the patient was strictly refusing any kind of surgery.
Well, once he talks to the surgeon, maybe not. Because the syntax score, I don't know, was it accurately calculated? It seemed a little low.
It was done on table, yeah. But it was much higher for the mortality for PCI. It was not. Yeah.
Is it diabetic?
Yeah, it's multiplied 3. Yeah.
Right. The surgeon, yeah.
Yeah, but we discussed about.
This is the art team. So, but in Massy, I think they are still doing art team for very complex lesions like this. But this is a discussion between surgeons and interventional cardiologists, and we build a kind of consensus. And after that, if your proposition is surgery, so we call the patient to see the surgeon, but a majority of cases, the patient are not going to the surgeon.
Yeah, but with the ChatGPT now, the patient already know the whole procedure, what surgery means and what PCI means. He explained me on the table that I know what surgery means. They cut the sternum, they put this wire on the sternum, and you fill the wires after it. So no operation.
You have to do what is best for the patient.
Yeah, of course.
Hey. Then, what about the CTO of the right?
Well, at this moment, there was the kinetic of the ultrasound kinetic. We didn't know spectra of the patient, but the ultrasound was with no hypokinesia on the inferior wall. So probably it was CTO, but it was a huge collaterals. I am not CTO operator, so I didn't went to any.
But this is also part of the, forget about the CTO node, but we know that this is a very big right, and the incomplete revascularization has adverse effect outcomes. Plus the fact now that you have a right system depending on stents implanted in
On
the
the
left. Should something happen, this is fatal. So it's not
Yes.
about if you can do or not you can do, but as part of the decision making, this patient has to be revascularized because he came on the table third time. He was not. So the decision making about revascularization or not should be in a different setup. Because this right is super dominant. It's a very big concern.
This is a good idea. So the next we will call the
In
patient
our-
for that.
In our place, we are lucky enough to have MRI, and so we can evaluate in details what is the viability. I mean, if you are at least 50%, 25% of the thickness which is viable, there is a potential recuperation, not quickly, but after 1 hour, 1 year, 1.5 year, sometimes it's coming back. Is more than 50%, of course 70% viable, you have to treat the patient. So I follow the idea of George.
Don't forget that this belongs to the category of the cases that you don't need an MRI in this case. Because there is no Q, there is normal ejection fraction, there is well prevented, and we know that in 50% of the cases, with CTOs, there is absolutely the silent occlusion. And in these kind of cases, you know that the muscle is not affected at all.
I will be provocative. Coming back to surgery, finally we have the results from the Nobel study, and Syntax score and diabetes are no predictor for worse outcome, especially for mortality in 10 years follow-up. And for the first time, Dr. Zhereva, who is not taking care about what we're speaking, she mentioned this in her PhD. We have, how many patients was? We have more than 600, but at that time, and even in a small number, that it turned out that Syntax and diabetes were not predictors of worse outcomes in left main stenting. Yes, in left main PCI, let's say. So this is something that will come probably in the future. But even the Nobel trial that was, let's say, not that favorable in terms of initial results, confirmed no difference, 10 years in mortality, and Syntax score and diabetes were no predictors. Dobry?
Okay, next one. Thank you, Sashko. Next one will be Dr. Maksudov. I suppose that would be a peripheral case.
So, good afternoon, colleagues. I will change the focus a little bit from complex coronary interventions up to the peripheral. So, in our cath lab and worldwide, the diagnostic angiography for the peripheral disease is the usually axis that we use, and in worldwide statistica is the radial axis. Most of the procedures are done by the femoral approach with crossover and anterograde through brachial approach. 90% is numbers from worldwide statistic are done anterograde because of the support. But in case of unsuccessful attempt, 10% of the cases are retrograde, distal SFA, popliteal, proximal tibial, anterior tibial artery, dorsal pedal artery, and distal posterior tibial artery. So transcollateral recanalizations is very rare as a method and is very challenging as approach. In our cath lab, which is achieved by Professor Vasiliev, we are doing a lot of retrograde approaches, more than probably 40%. So, which are the general rules in critical limb ischemia? Is that 1 vessel is acceptable, 2 vessels is not too bad, 3 is better, and all is the best. This is 71-year-old patient with polyvascular disease. How to say, he got maybe more than 12 PCIs and PTAs, not so many. Also got cabbage with a couple of stents in the both carotid arteries, in the left subclavian artery. So he was admitted in our hospital with acute left leg pain. He was with chronic claudications for 4 years. You can see that he's diabetic, he's with hypertension, and he smokes 3 packs of cigarettes per day. This is his angio. You can see that there is occlusion, ostial occlusion of the superficial left artery. There is high-grade stenosis of the popliteal artery, occlusions of the both tibial arteries, and mid-occlusion of the fibular artery. And there are collaterals for the distal anterior tibial artery and the fibular arteries. So, not so good candidate for the vascular surgery because there is no good good landing zone for the bypasses distally. So what we have done here, first of all, the angio was done by left radial approach with 4 French. We have changed for the PTA. In first step, our plan was to open the left SFA. We did the left brachial approach with long introducer of 90 centimeters with 6 French. We go with the Terumo wire. After passing, we did several predilatations with smaller and bigger balloon. After that, we put a stent over there, and we optimized the result with drug-eluting balloon because the stent is bare metal. This is the result after opening the ostial AFS. Then, for better support, of course, we have gone with the antegrade approach. We have puncture just above the just delivered stent, and we did the POB of the posterior tibial artery, but we didn't access to pass through the occlusion. During these maneuvers, we managed to make a dissection of the popliteal artery that was resolved with predilatation and afterwards with DEP. So this is the result after the DEP of the popliteal artery, still nothing below the knee. So we tried to pass into the fibular artery, but there was also unsuccessful try for that. Then we go to the third step, of course, retrograde approach. We did the puncture of the dorsal pedal artery under the X-ray with contrast under the X-ray and contrast media from the anterograde left femoral approach. And you can see on the second video there is introducer into the distal tibial artery, and on the third video there is a dual injection from the anterograde and retrograde. We did kissing wires from retrograde and anterograde. We tried to use card technique, a familiar technique for the retrograde CT operators, but we couldn't make enough space for the anterograde wire to pass into the distal part. So what we did, we managed to pass with the retrograde wire and with the balloon to go into the anterograde GR catheter, where we inflate the balloon and we make the stable system that we pull out from the anterograde approach, and we change automatically the access from the retrograde to anterograde. We did a couple of predilatations of the anterior tibial artery. We did kissing balloons of the truncus tibiofibularis and to the anterior tibial artery, and we close the puncture spot with the balloon. So this is the final after the third step. Good result of the SFA and to the anterior tibial artery. The contrast media up to now was 160 mils with 2 hours of X-ray time, and my back pain was still acceptable. We didn't want to finish the procedure only with one artery below the knee because it wasn't acceptable for our point of view. So what we did, we wanted to open the fibular artery. When we go down with the wire balloon and we gave contrast, we see that there is a small collateral from the mid-fibular to the distal fibular artery. So what we did, we passed with the hydrophilic wire under the support of the wire balloon. And we go with the snare. We catch the wire that passed through the collateral, and we did predilatation and make a space for anterograde wire to pass distally into the fibular artery. After that, everything was easy. So this is our final result. 2 is more than good for us. The wound, this is the picture of the wound of the toe that is probably around 3 weeks after the procedure. So we finished the procedure with 3 hours of fluoro. Contrast was 220 mils, and my back pain was really, the pain in my back was really, really bad. So what are the conclusions? That endovascular treatment of critical limb ischemia in diabetics can be very challenging. Usually, one technical strategy is not enough to treat complex situation, and transcollateral retrograde recanalization is very challenging and hard to do, but sometimes it's the only way to treat these vascular occlusions. But this is not the end of the case, because the patient lost from our side in a couple of years. He changed his work to another city. He went for a couple of procedures in another hospital. They have put stent into the iliac arteries in the common superficial artery. And when he get back in the town where I was working, he called me and he said that he got pain in his left lower limb and in abdomen, and while he was showering, he palpated something that was pulsating in his groin. He came, and on the Doppler sonography, the pleural aneurysm in the part of the external iliac artery and the common femoral artery was noticed, a large, around 6 centimeters. So we did CT angio, and the CT angio showed that there was a pseudoaneurysm, but also there was occlusion of the superficial artery, and we didn't know why. But that's why we did the angio of the arteries of his left leg, and you can see the large pseudoaneurysm, and you can see that the ball stent that they are put in the iliac artery and the common femoral artery and in different planes. Probably they were put it subintimally, and that was the reason why the occlusion of the superficial artery was occurred. So what we thought that this is going to be an easy case to resolve, just to put a cover stent over there, but it wasn't. We tried with a balloon and stiff wire just to pull and to put the stents in the same plane, but we didn't manage to do that. So we call our good friend the snare kit, and what we have done, we have puncture from above and from down. We go with the coronary wire long from above and from down with the snare. So the idea was to go through and through. We catch the wire, This was not so easy. This is approximately 1.5 hours of fluoro time. Afterwards, we go with the microcatheter. We put a stiff wire over there. We put a balloon that help us to put the stents into same planes. Afterwards, we put the cover stent, and this is our final result. So the most important thing is to emphasize the importance of openly discussion complications, so the transparency fuels continuous improvement, allowing us to learn and improve patient care. So today's success calls for open dialogue and cooperation for better results. Thank you very much for your attention.
So this is an example what happens when cardiologists start to do peripheral cases. Okay, so
I was doing peripheral too.
we have radiotibial, maybe more than 50 cases for the moment. Unfortunately, not all are completely, could be finished entirely from the only radio and tibial access. And it is highly dependent from the materials, because we have balloons which are 170 now, as a standard in our lab. No, with sheet, just sheets, but long sheets. We place a 90 centimeter sheet, even 7 French through radio, just to have enough support from radio, and everything as a stenting goes through the tibial axis when you go through.
You can use guiding catheter coronary 110.
Yeah, but 110 will be just
It comes to the inguinal region, to transbrachial.
It depends how
Tall.
tall is the patient.
So I want to raise the point. For me, it's important. I was doing a peripheral intervention, and not a lot. Why? Because of difficulty of protection of the operators. And we don't have a real solution. When you are working under the, you are looking the femoral, you cannot, you do the puncture there, so you are not protected. So I think you probably have to limit the number of patients. I've not found any solution for this. You have drape now with a lead inside. Can improve, but you have to do your best to protect not only yourself, but the environment. I think it's a very important point.
Thank you, Oki.
Thank you.
And Sashko with his second case.
This case is done 7-8 months ago, and it's privilege because I'm here in BBC meetings since 2014. I've missed only one when the COVID was started, and after it we are coming here again. And this is my wish for this case for the first time to be presented right here. What's next when everything else fails? So this is a patient, 55 years old, with a gangrene on the right foot, with a heavy calcified arterial system, extremities, aorta, brachial, arterial, radial, everything was calcified. He was denied for vascular surgery from the surgeons, and he came to our hospital for endovascular procedure. We attempt, but we couldn't pass the heavy calcified superficial femoral artery. Even when we were trying to puncture the artery, we managed to crush several peripheral needles. So he was submitted for high leg amputation, but the orthopedic surgeon said that there is a very, very low peripheral collateral. So it was risk after the amputation the wound wouldn't heal. So I was thinking for 24 hours what to do, and I found some studies about below the knee vein arterialization. I think here Professor Rigatelli was having one case 10 years ago, I think it was. And because it was in the high femoral region that actually there was no blood, I was searching something that we can find to communicate between the proximal part of the femoral superficial artery and the vein system. And this was the percutaneous deep vein arterialization, but I didn't have the materials for this kind of intervention. So I said, why didn't we use the great saphenous vein? So this is the CT scan. We usually do the CT scan for every patient that is going for a peripheral intervention. You can appreciate the huge calcificate arteries with no blood flow in them. So this is the attempt. We tried transbrachial, but nothing was coming down. We try anterograde directly puncturing to the femoral superficial or profunda. Nothing was going back down through the calcificate arteries. So by ultrasound the next day, we punctured the great saphenous vein in the distal femoral region. We put the introducer and we put the snare up to the groin somewhere 10 centimeters from the venous-saphenous junction. We puncture the snare through ultrasound and angio. And after puncturing the snare in the middle, we put the needle to the femoral artery, to a calcified femoral superficial artery, puncture the femoral artery, and put this is a glide wire 0.014 wire, and we made externalization through the catheter from the brachial. So in this moment, we were from the out of the body, through the vein, through the muscle, to the artery, out to the brachial artery. So we put the introducer system inside. We make the picture that we are right there. So the introducer system is from the leg, through the vein, through the muscle, to the femoral artery. We make the predilatation with a 4-0 balloon, and we put the first graft stent from the femoral superficial artery through the muscle, and the second stent from the muscle to the saphenous vein. We try to cut the valves of the great saphenous vein, but didn't succeed, and we put the supera stent all the way from the graft stent down to the vessel. So this was the final result after putting the blood from the artery to the superficial vein. The patient, after 5 days, after the arterialization, went for the amputation, and the results of the orthopedic surgeons was very satisfying because there was a lot of bleeding during the amputation, and they were happy that the patient will be quite good. And the amputation was below the knee now, not above the knee, below the knee amputation. After 2 months, the same patient came again now with a gangrene of the left foot. And according to the experience that we had from previous intervention, now we decided to use the perforator veins because only the perforator veins doesn't have valves. So we won't spend more stents on the vein. We already did the Doppler sound of the vein system of the both legs, and we knew that he has a huge perforator vein on the left leg. So before we started, transbrachial, we managed to capture the right leg after 2 months from the arterialization, and you can appreciate that this superficial, the great saphenous vein now has become a great arterial vessel that actually, with all perforators, are giving arterial blood to the whole leg of the patient. On the right picture, you can appreciate the huge calcified stenosis and poor vascularization and collateralization of the left leg. So we start the procedure. We puncture the perforator vein somewhere near the joint of the leg and put the snare near the part of the superficial femoral artery where there is blood. The same thing, we puncture through the skin, the snare, from the snare to the femoral artery, put the wire, externalize the wire, and this is the introducer 90 centimeters the destination, 6 French. Make the predilatation of the femoral common and femoral superficial artery, then predilatation from superficial artery through the muscle to the vein. And this is the final result. Actually, with 2 graft stents that we put it from the superficial, you can appreciate the flow that goes down to the foot of this patient without need stenting the valves, because there is no valve in the perforator veins. So this is after 7-10 days, because the left leg was with the gangrena, swollen, infected, probably because of that, and the collaterals that were down to the foot were occluded, but he received another below the knee amputation, and again with a very satisfying comments from the orthopedic surgeon that there was a huge bleeding during the operation. And before I came here 5 days ago, I spoke with the patient. The patient is now in rehabilitation, where he has this orthosis, and they are teaching him how to walk. And the main thing is that now he said, I'm less taller than I used to be. So if you choose the job that we love, we will never walk a single day in our life. This is the mind that Confucius said, and I think this BBC club is full of this kind of person with our job. Thank you very much.
Fantastic, yeah. That's creativity, yeah. That's something we like in our job. We have new ideas. Of course, you have to test these ideas with to register the data and with normally following the law.
Yeah.
But there is no solution. You can be brave and find such kind of solution.
Yeah, we have
Congratulations.
after the COVID, we have a lot of patients. Probably all the cath labs have this huge thrombotic material in the whole arterials, and you can do nothing, even thrombolysis, nothing. And this is the way for amputation. So we do it 2-3 more cases with the arterialization in this period, in this kind of cases. The thing was, we don't know how to find the results, how to connect it from the superficial, from the saphena great vein down in the below the knee to put the blood now directly to the arterial system. I'm thinking that kind of solution to find it, and if I find it, we will do in situ bypass. This is the main problem that we are facing this after several months, because it's easy to amputate. But the thing is, we don't have the right solution how to connect the blood down to the foot from the vein.
If it is not a desert foot, because this, I'm not expert in this, but we're doing some peripherals. But this is a very good solution, and it is done even below the knee, just for patients which has this the so-called desert foot. In fact, they don't have arteries in the this is a very small network, and this is an option to, in fact, to save the limbs of this patient.
Yeah.
Just redirecting the blood from some of the arteries into the vein, into the capillaries, and they're going back through some capillaries.
I have a friend in New York doing this kind of things, so maybe I can give you the contact. So
Yeah, it will be good to discuss about this.
build, I think, a network, to get the information. These things are unusual. So,
We are on the halfway, so
but
this
the
is not-
consequence and the advantage for the patients are incredible.
Yeah, but using the saphena, the great saphena vein, it's very easy than using the deep vein, because there is a study for the deep vein arterialization, but there is always a risk for a deep vein thrombosis. But when you touch the great saphene vein, zero. So it's much easier, much to go there and to finish the job. But we haven't found the solution what to do with the below the knee. If there is no gangrena, we want to make the whole circle. Thank you.
Thank you, sir. Great case. Thank you once again.